On the left, yeah.
You're saying that's good?
No.
Okay, because you put flexion, you put bending forward.
This one here would be bending to the left with blockage, pain on the left. This one would be bending to the left with blockage, pain on the right, because the arrow goes to the right.
And
that's good.
Okay, because you put the good flexion thing with the bad other thing. So I.
Oh, okay, yeah. Picky. That's good. That's very good. I didn't mean actually that it was good. I meant that it was the only. It's not good to do that, but it's not like it's not terribly bad like the other things are bad. He considered that to be kind of not a neutral thing even, but not like a contraindication and a bad sign of predictability. Yeah. Thanks, Andy. Any other things? Bilateral symptoms, yep. Anything else?
Saddle.
All right, saddle anesthesia, yep. So we can now go into the very important ones. Saddle anesthesia. Okay, yep. Bowel and bladder, yep. Because these are what? Cauda equina lesions.
Anything like positive Babinski or any type of other spinal cord sign.
Yeah. If you had a positive Babinski and any of the signs that might go with that, like ataxia, hyperreflexia, that kind of stuff, what level would we be talking about?
L1.
Yeah, above L1, because we're dealing with a lower motor neurone lesion below that. So it would show us that there's something very inappropriate going on, perhaps at a different level to what we're dealing with, but it would mean that this patient should be very carefully investigated neurologically and not by us.
Vascular problems like throwing a clot in the femoral artery. Had a patient that had something like that. She had pain in the leg, but ultimately she developed a phlebitis type thing down in the lower extremity, and she had to go on Coumadin. The reference for the pain down the leg was a real odd presentation that it could have,
Yeah, I think that's a really important point, Bill, in terms of what you've said, but also in terms of patterns that seem not to fit a musculoskeletal kind of behavior. First of all, patterns that are outside the normal mechanical problems of the lumbar spine, many of which are L4 downwards. I'm not saying that they don't occur at other levels, but if they start occurring at other levels, we should be kind of a little bit careful about what we do. And there's been a couple that my colleagues picked out. One was a young woman that had a femoral vein phlebitis, and the pain was just very, very different. That one I spoke about, it was a different pain. He'd also got swelling, and you don't get this unless a patient is limping so badly that you can get the swelling caused by the limp. But I think you should investigate it and not just assume that it is. Though these are outside of what we know as our profile. And this is why the fixed profile is so important, and why Cyriax produced so much good stuff, because he produced this excellent examination that he did. And everybody that were trained by him, the creme de la creme, of which Anne is a member of that group, that select group, okay, did this all the time, one after the other, and it was really, really important.
The other thing is your odd sensory disturbances, like with your MSs and sometimes you don't always get your Babinskis and stuff with your MS patients because they have such odd presentations. So the other things that I've seen are odd presentations with your connective tissue diseases, and, your lupuses, your alcoholic neuropathies, and they all have just bizarre patterns. And sometimes if you don't pull that out,
but The question is, have they got articular signs in the back? This is the thing that we're really looking at. We're looking at this whole profile, aren't we? And you know, if you don't have anything here and we've got these weird things in the legs, we're kind of wondering, is this coming from the back? You know, and sort of further investigation needs to be done, which is why we're part of a team.
We have superimposed things.
Mm-hmm. It's not sort of like the common thing, though, is it, in terms of musculoskeletal practices? And I think if we deal in terms of probabilities instead of like possibilities, but that's a really important point that, you know, we all see these that we just can't work out. And I think these are the ones that we think about a little bit and we sort of send back because it doesn't fit how we are predicting we should be going. And with musculoskeletal things, there should be a fairly rapid resolution. It might not last forever or anything like this, and we may have to keep on doing it, who knows. But there should be some change in what Maitland called his salient signs, which are what we would tick with Cyriax. Any other things here?
Hyporeflexia?
Yep, we've spoken about, yeah. Or if we look at neuropathy, if we've got a, we don't want neuropathy, but if we've got it, it shouldn't be, 2 segments was acceptable with Cyriax, but it still would be a big prolapse and to get neuropathy. So it's good for a manipulative thing. Looking back at Day Earl's thing, because we've got so many other ways that we can tackle the ones with neuropathy by traction, by distractive mobilization with hold and so forth, that we wouldn't be manipulating those. Anything else within the profile? Have I got everything there, Anne, in his signs of?
I guess the only other thing I would add would be that somebody who had 3 movements limited was always the classic good one to manipulate, things being okay.
Yep.
The person that has 6 movements
Yep.
limited or 1 limited was not a good candidate.
Okay, I'd forgotten that one. Okay, so here we are with our classic kind of thing in terms of movements, that there should be some movements free in some directions to signify a dysfunctional state, either an intra-articular block or whatever. Some movements should be free. But Anne sort of brought up that thing that if only one movement, did he ever describe why that was?
Not in the lumbar spine,
No.
in the cervical spine,
Yeah. And what was his explanation for that?
That often side bending away may indicate the classic was the Pankhurst.
Yes, okay. This is why, you know, to go back to his book time and time again, it's just one of these, like Bible books, you know, there's no question. You know, there's stuff we can leave out, and some of his, that's quite attractive to read once, his sort of tirades against various groups and stuff, but you can kind of tear those pages out and then stick with, you know, just the real stuff, and it's just a wonderful book, there's no question. All right, any other things? We've got a good profile here. Now, what we haven't got, because Cyriax didn't do it, was instabilities. And so we should look at instabilities as a test now. What are going to be the signs of instability for us?
Inconsistent pain.
Inconsistent pain, inconsistent movements, sometimes a consistency when they bend forward to go into a sort of locked lordosis position, because we know that it's a lot easier for a person that is unstable to go down where they're hanging on the ligaments than to start coming up where the facet movement, one against the other plate, has got to be controlled. And this is when we very often see them go down and there's perhaps a deviation. Next time they go down, it deviates differently. But when they come up, they try and lock the spine and come up from the hips rather than from the spine itself. And we should be sort of thinking a little bit about instability. So, what are the tests for instability that we should do? Let's just go over these, and then you can just run through them just for completeness, and then we're into doing the manipulations and so on. Chris, I'll just get you on the table here, please. I'll rapidly go over these. If these are totally familiar to you, and I'm sure they will be, then we can just quickly do them to make sure we haven't got a problem. Yes, laying on your back, please, and then come and face me, please. Okay. All right. I'll get Chris in this classical side-lying position, and what I need to do if I'm going to test any of this for hypermobility is to make sure that the spine is in its lordotic position and that there is no side bend on this. Do you remember, if we were testing an anterior cruciate, we wouldn't be at the end of the anterior cruciate's movement, we'd be at the middle of the movement and see if we can shift it along its track. In other words, along the translation movement. So we must make sure that this is straight. And one of the things that it would be important is, say, in a female patient, that perhaps their hips were a little wider, that then they are dropping down into a side bend position, which we didn't notice, which of course takes it to the end of a range of motion. So make sure that all that is neutral. Now then, we've probably could go over some intervertebral joint motions here and look for, before we start doing any of this, to give us an idea of if there is any instability, to look for anteroposterior movements like this, doing one leg or two legs, whatever you like to do. If I find one that feels a little bit less mobile, I'll note it. If I feel one that's a little hypermobile, I'll note it. And then I'll try and get one that feels to me to be kind of average. And having got the hypermobile one and the average one, I'll try this, is to go into the normal one that you've made an assessment on and gently palpate along the spinous, interspinous ligament, supraspinous ligament and so on, and go to the attachment points above and below so that we're on the bone, because that's where most of the nerves are. Then I'd come down to the one that I suspect is hypermobile, and I would gently palpate it at its periosteal attachments. A joint that is hypermobile, the ligament working over that joint will be very sensitive. I know that myself, very sensitive, okay, with my thumb, which has been practically cured by Barbara. Okay, so here we go in here, and, or not cured, but controlled, I guess. Never be controlled. She's told me this will never clear up. So I'm going back on Monday and I'm selling my practice. Okay, so here we are. We'll just palpate that interspinous ligament, and Evian was the one that said that any joint that is hypermobile, that has been absorbing these stresses in one or two structures, the interspinous ligament will be extremely sensitive, and that seems to work out very much for me. If I come over it and it's not, I really wonder whether I'm making more of this than should be, because if it's unstable, it should be very sensitive. Now I know where I'm going to sort of apply my kind of testing. I need to have a normal one and I need to have my abnormal one. And the first thing that I would do here is to do an anteroposterior pressure, and that is simply to push along the leg like this, keep my hand on my thigh and just push like this, that movement. And I'm going to push in the direction of the intervertebral disc. So I'm not going to move very much. If I want to come up a little higher, my L5, I would push S1 that way, 4 a little bit more that way, 3 a little bit more that way, 2 a little bit straighter. And that's how I would do that pressure, just pushing up through my knee like this, doing the anteroposterior pressure. Now, I'm never as good doing the postero-anterior pressure. It doesn't seem to work as well, but we have another test which will show this later on. So that would be my first little maneuver going through these pressures, to try and focus on one level. So I'm not putting strain on every single level. The next thing that I would do would be to try and have a look at the relationship of this joint to absorbing my rotation in this position. And I'd have to obviously do it both sides. And there are two ways of doing this. This is one, and it's a little bit cumbersome, I think, because you've got to roll them from one side to the other and then set them up so that they're in lordosis and so on. What's possibly a slightly better test, or how about better but more convenient, is to lay on your stomach, please. Like this. Let me see if I can. No, I can't do it with this table. Let's just simulate the table coming up in the middle a bit with this thing here. And I'll just stick that under Chris's middle. And so we've now flattened out the lordosis. In other words, I've tried to disengage the facets a little bit. And I'm going to do the Rosette test, which is to simply come onto the spinous processes like this and just produce rotation like that. And I can try rotation both ways simply by working my way up the spinous processes, and I'm pushing the superior one against the inferior. So I'm producing a rotation at L5S1. I change around, I produce a rotation to the opposite side. Then I change my thumbs, go up one. Change my thumbs around, try the other side. And this is actually quite a good test, but it has to be done in a flattened lordotic position where you are actually putting more stresses on the softer tissues rather than on the intervertebral facets. The next thing that I would look at here is to go on to looking at postero-anterior pressures, and I will try and engage the facets here a little bit. And the two ways here, is it a soft end feel or a hard end feel? It depends on whether you push from distal to proximal or proximal to distal. If I produce the movement from, or caudal, cephalic, cephalic caudal, if I produce a movement on the cephalic one, I'm pushing the facets down, let's say between 4 and 5. If I push 4 anteriorly, it's putting the facets close together. If I've got some erosion of that anterior J, I'll find difficulty in finding the end range of this. On the other hand, if I do the caudal cephalic one, I'm putting a stress on the discs. So you can just do a little bit of motion there and see if you can detect any difference when I come down. How am I going to get my sensation here? Okay, if I come down like this, yeah, I'll have to take this one off there, then I could come here and pick it up the other way. That will give me the capsular end feel. That should give me the bone-to-bone end feel. There should be a little difference between those as I come up. All right? Next test to do here is probably to then go on to Farfan's rotation torsion stress, which is to come around the anterior part of the body here, to pick up L5, to move in and to rotate the spine so I'm getting a left rotation. And I know now that I've got to try and analyze what's happening on each side. As I go into left rotation, I'm getting a gapping on the left side, aren't I? And a compression on the right side. And pain on the right side, in my estimation, is more significant, because it means that we're getting compression, pain. What's causing that? Is the sum of these things that Farfan used to talk about, the subchondral fractures and all this kind of thing? This might be one of these to actually apply continuous ultrasound to see whether it's exquisitely painful. And then perhaps these are the ones that should have bone scans and so on. Farfan said you could tell the fractures from ordinary x-rays, but I don't know that anybody else has ever said that. Now, his test was a little different to what we've been doing. He used to do this, and then he used to go from above downwards and say, okay, let me just test that again. And he used to pull like this, and if the patient got pain by doing this on the same side, you were, of course, producing two opposite rotations here. And that used to make him mad, because these were inconsistent findings. So if he did say, no, that's perfectly all right, and then he came into this side and lifted up, no, that's the pain again, then this was consistent findings for this torsion test. Now then, we can use Pheasant's test now, which is a way of going into looking at an unusual anterior shear that might be sort of present with a spondylolisthesis, for example. And this is done like this. You take both legs, and this is described in Kirkcaldy-Willis's book, of coming up like this and pushing into flexion of the knees, which tightens up the rectus, pulls the ilium into anterior rotation. Now then, here's my little modification of this test. All right, we get pain when we do this. Is it because I'm stretching the ilia? The pain has got to be in the back. Now then, if I come onto the base of the sacrum, or sorry, the apex of the sacrum like this, and I produce pain, then I come with Chris and I do this and I push down on the apex of the sacrum like that. Obviously what I'm doing is I'm going back into a flattened position. So I'm stopping that lordosis. So we produce the pain, and then if I can remove it by just pressing on the sacrum, I would suspect that any pain that he's talking about is because I'm increasing the lumbosacral angle. And when I do that, I reduce the lumbosacral angle. And I could then come up into this position, back off a bit so he doesn't get pain, go to the base of the sacrum and press down and increase the lumbosacral angle, and the pain comes back. And so I can remove it and I can increase it either remotely or locally.
How does that test for instabilities, or it's just
It just tests, well, because when we go up here, we're sort of saying that this must be rotating like that, it must be pulling the ilium forward, and how does that fit with all the other tests that we've done here? The ability of this joint to absorb actually gravitational strains forward, that's what we're doing.
What's the difference in between the apex and the base when you've got like 30 of pain?
Because if I have got that in this orientation here, we take both legs back and that happens, and it takes the sacrum forward and produces an increased arch there. So then I come on here, I hold the increased arch, and I get onto the apex, and I push up here, and I reduce the lumbosacral angle. Now, I take off the strain that's doing that, and I come up to the base, and I push the base down and push this
That increases the angle.
angle again. And does that cause the pain? Okay, so that it's a way of trying to get away from the hips and the thighs and all the other things that patients grumble about when you're doing any of these tests, which kind of obscure you. So you now sort of say, okay, this is the remote test. Can I do anything sort of more locally around that bone? And if you can and you can do it, sometimes you can do it one-legged and sort of bring the pelvis back, the same as you do for looking at iliolumbar ligament strains and so on. Yes?
I'm sorry, go ahead.
So this tells you that there's pain there at the LS.
Tells you there's pain there, then you look and you think to yourself, okay, when I was doing that, there was more movement there, and this joint is probably inadequate at absorbing the lumbosacral angle.
When you're doing the side lying.
Yeah, and these must all go together.
So that one is specific to L5S1.
Yes, yeah, I think so. With Farfan's test, of course, the problem is, in terms of rotary instabilities, is that if you've got a pain at 5S1, there's no point in going any higher, because it's going to hurt as you go through 4-5 to 5S1. It's going to hurt at 4-5. The only way to do that would be to come back or to lay them in side lying and then to torque it back from above downwards.
What do you think's happening with this test with Farfan's? It compresses which side?
Well, if I lift this side, it's the same as rotating the spine to the left. And with rotation to the left, we've got gapping on the left and compression on the right. Yeah. And then, of course, he did his compression test, which is to lay on the back, which was more significant in young people. That's under 20, where compression strains are probably more common than rotational strains. So we come up to here, we just keep it on here, and of course I'm now doing a line that is parallel to the table, so I'm pushing up in that way. Farfan used to talk about discs that were going to be positive with this, that on x-rays looked as if they had the same height back and front. There was not the characteristic wedge you see in the lumbar spine, and this sort of fitted. And he had 3 patients the day I spent some time with him, all of whom showed this, and all of whom were under 18, and all of whom were female. And he just sent them to bed for 10 days, just to remove any compression loading. Whereas we know with bed rest, after 2 days you start to go downhill. But this is probably one thing. But who's going to get an 18-year-old stay in bed for 10 days? Probably not very many people. Now, are there any other tests you want to put in here? Well, when we come round, you can do what things you are doing as well. I don't know, you picked up from other people, that's fine. So let's very quickly go through just the instability to make sure we're not dealing with any of this, and if we are, how can we absorb it into our levers without any detriment? All right, let's go.
David, I have a question.
Yeah.
Do you see much discrepancy between the sitting straight leg